Information from this video is not to dispense medical advice nor prescribe the use of information as a form of treatment for medical problems. Please always consult with your physician or medical team on questions you have.
Thank you again, Dr. Hanson, for being part of this discussion on dysfunctional breathing. So, the blog that was discussed talks about how we seem to become a little desensitized regarding the severity of a snore, or more importantly, dysfunctional breathing. And I was very impressed with the video I saw, and where you're kind of highlighting the stress response that occurs when our mouths are just open. And I was wondering if you could just elaborate a little bit on that discussion or that concept or topic.
Yeah, thank you. It's a huge thing. We could talk a lot about this one. However, I'll try my best to keep it short. So basically, when the mouth comes open, there's a bunch of things that don't happen for us. We don't warm, filter, and humidify the air through the nose. And we don't get to mix the air with nitric oxide, which is formed in the paranasal air sinuses. Nitric oxide is antibacterial and antiviral, and it's also bronchodilatory and vasodilatory, so it helps to keep tubes open. So it's kind of useful. The other thing when we don't breathe through our nose and we breathe through our mouth is that we tend to have a habit of breathing a slightly higher volume of air. So if you were to measure the amount of air going in and out in 1 minute, which is called the minute volume, you would find that it was greater for someone who's habitually a mouth breather in most cases, because the nose offers resistance to the flow of air and slows the flow of air down. So not only is there a bigger volume, but there's also a greater speed or velocity of air. So there's a couple of things that are happening because of those two factors. First one is when air moves faster, it loses pressure. This is basic fluid dynamics that we learn in physics. As air moves faster, it loses pressure. So if you've got fast air moving through your airway, which is a tube, pressure is reduced and airway collapsibility is increased. That's called the Bernoulli principle in fluid dynamics.
I absolutely understand that through swallowing dysfunction. We talk a lot about the pressure systems above and below the glottis.
Yeah, absolutely.
Positive and negative pressure occurrences happening.
Absolutely. So if you're sucking on a thin paper straw, a cheap paper straw, if you want to get that liquid through, you got to suck it gently. If you suck too hard, it will collapse, right? So same for air. You want the air going through the airways nice and slowly and gently all day and all night long. Unless, of course, you're exercising, you might have more different metabolic requirements in those moments. But basically, that's point one. Point two is more of a biochemical kind of reason. So what happens when we have that bigger volume of air is that we're not just taking air in, but we're giving exhaled air out. And each time we do that, we're expelling carbon dioxide. Now, there's only 0.03% carbon dioxide in the atmosphere. So when we breathe air in from the atmosphere, we hardly take any carbon dioxide in at all, but we give a lot of it out. And if we're optimally healthy, we give out around about 6 to 6.5% concentration of carbon dioxide. By breathing more rapidly, kind of like this, like snoring, or just with mouth breathing on a lower grade level, we're giving out more CO2 than we're taking in. And the net effect is a decrease in carbon dioxide levels. And in 100% of clients that I've ever put on a capnometer, which measures CO2, if I get them to breathe a greater volume of air than what they are naturally breathing, CO2 always falls. So then we have something called the Bohr effect. So Christian Bohr came up with this, and it speaks to the changes in the affinity of oxygen on hemoglobin with different concentrations of carbon dioxide. So hemoglobin is amazing. It picks up oxygen in the lungs where CO2 is low. It has a high bond strength in those situations. And it releases oxygen at the cells of the periphery where oxygen is needed, where CO2 is high. So that differential of carbon dioxide concentration allows for this pick up and release thing with hemoglobin. So when we breathe a big volume of air and we have this kind of natural low grade kind of default level of carbon dioxide, a relative hypocapnia, we would call that, what happens is oxygen is not released so well. And so we can have loads of oxygen in our blood supply, but it's not being released so well. So people say breathe more and get more oxygen. it's impossible. If you put a pulse oximeter on your finger and you've got 98 or 99% saturation, you can breathe as much as you like, but you're not going to get more oxygen because it's already full. So the key is to breathe correctly for your metabolic requirements in that moment. So CO2 and oxygen are balanced. So oxygen is effectively being delivered and not just kind of being held and delivered a little bit, but not delivered so well. We end up with a relative partial cellular hypoxia when that happens. And so cells get oxygenated. They just don't quite get as much oxygen as they were like. If you're a nerve cell, you might feel numbness. If you're a brain cell, you might feel dizzy. If you're a mucus secreting cell, you might secrete more mucus as a stress response. If you're a bronchiole that keeps your airways open, if you're a smooth muscle cell of those bronchioles, you might spasm if you have the asthma gene, and that's the way you express it. So you then have an asthma attack. There's all kinds of different things. If you're a muscle cell, you'll go into anaerobic glycolysis. You'll start creating lactic acid and get cramped during exercise. So really, we need to be breathing normally because every cell in our body needs an adequate supply of oxygen. And so we can demonstrate all these different changes with all of our pieces of equipment, and it's great. But the take-home message is breathe normally. You don't have to breathe anything specially, but you need to breathe functionally.
So I have two things I hope that you can elaborate a little bit. So there's two anomalies within my profession. One is this constant globulous sensation that people with swallowing dysfunctions, especially on G-tubes, complain about. So they complain of this saliva buildup, constant saliva buildup, very similar to reflux, a mucus-like reflux. And they're constantly having this bubbly-like saliva that just will not clear. It's very goopy. And most of the people that say this to me are older and are on modified textures because of swallowing dysfunctions. But they do have reflux as a common symptom, right? And I'm beginning to think perhaps what you're explaining could be a dysfunctional breathing component that's affecting an already damaged system. And
yeah.
That just popped in my head right now. And then the second thing is the airway collapsing. So that's another thing that I've heard about, not necessarily associated with tethered tissue, just that the airway collapse. And this is a recent discussion within my profession where people don't necessarily have apnea. They just feel the collapse of the throat or the mouth dropping in positions. And there's a therapy technique that I use with kinesio tape to kind of keep the proprioception happening, where we add tape right here, right below the glottis, where we pull the skin down when someone's sleeping. And so there's applied pressure that keeps, for whatever reason, that from not happening. But I mean, you can't keep tape on your whole life. You can only use it intermittently per se. But what are your thoughts about that?
Yeah, wow, there's a lot in there. Hey, there's a few different pieces. So if I might come back to the reflux part, which you started on, I can't answer the thing about the tube and in relation to your profession because it's definitely not my area of expertise, and I'm not into professing things I don't know about. Yes. But what I can talk about is the reflux side of it and what can happen with breathing dysfunction in relation to reflux. Okay. So there's two sort of things. When I'm working a lot with the infants, for example, when I'm doing my frenectomy procedures, if they have aerophagia and they're breathing in a lot of air while they're swallowing, they're swallowing a lot of air, then that can lead to gastric issues and reflux and wind and all the rest of it, right? Which then can be expressed as colic type symptoms and those other things. Then when we get a better seal on the breast or on the bottle, they're not taking in air because their muscles are working correctly and they get a proper latch. We then find that they talk about the reflux is going away when it's not caused by something else, of course. So that's one piece, is the swallowing of air. The other piece about it is what I was speaking before about the Bohr effect and cellular oxygenation. So the muscle, the sphincter control can be affected by it essentially. So you have the sphincter there that's stopping fluids coming from your stomach up the esophagus.
Correct.
And that sphincter is controlled by smooth muscle. When smooth muscle cells are not adequately oxygenated. So of course, all cells in the body are being affected by this breathing. It's not just one specific area, but the the symptom will be expressed somewhere or in multiple places. And so if the sphincter is spasming because it's not getting adequate oxygenation, then poor sphincter control can happen in some cases when there is breathing dysfunction. And that could be one reason why you're getting this kind of reflux kind of situation happening, possibly. The other reason, we go to the nervous system. So saliva control is under the parasympathetic nervous system, which is the rest, digest, heal, repair, immunity kind of side of things, rather than the fight, flight, sympathetic nervous system. And while both sides of the autonomic nervous system need to be firing and working all of the time, if someone is dominantly in their sympathetic because they're just not oxygenating their cells properly and they're not sleeping well and they've had years of this, if they're dominantly in sympathetic, we can get things, for example, in the dental world, things like dry mouth. You get dry mouth if you're anxious, for example, right? And that's because you're in that fight flight mode, which doesn't really care so much about digestion and salivation. So I don't know, there's a few things that may relate to the specific thing you were talking about, but yeah. And then there was other pieces in there which I can't remember. You kind of spread it around some other areas, and I can't remember exactly what you said. Maybe you can.
Well, with all due respect, I think what you just gave me right there is all I want to. That's just where I want to stay.
Yeah, that's great.
Yeah, it's always been an interesting factor. So, long story short, no matter where I go and look at literature or anecdotal reports or therapists or whatever, the underlying problem always seems to come back to breath. And it just makes me wonder, perhaps, how do we go about knowing this information? Like, how do you fix this? How do you address this? Oh, the other one had to do with airway collapsion, where it's not apnea related, it's more like an airway collapse. But I think you hit it on the head already with the sphincters.
There's one more. There's actually one more piece, just to circle back just for 1 second on that, if that's okay. So, and in relation to the breath as well, is that mouth breathing relates to low tongue posture. You want the tongue in the roof of the mouth to help develop the jaws, and for swallowing to be normal, as you know, we shouldn't have a great deal of contraction, if any, of this orbicularis oris mentalis buccinator. It should be really all in the lips together, relaxed, tongue moving. And so if we are constantly mouth open, low tongue posture to allow the air to pass over the tongue, the actual structure of the jaws changes. So we have a more narrow maxilla, and the mandible then quite often will fit further back. So we get this retrognathic situation with the jaws, and that also predisposes, of course, to airway collapsibility because the tongue is held closer to the airway. So there's the other reason. So you got a structural component because of the sculptor of the jaws and face that I was talking about earlier on in the, I think I might have talked about it earlier on. Yeah.
Yes. Wow. This has been incredibly enlightening. It really has. Apnea, well, for me, oral cavity health is my nemesis for pneumonia. That's the one thing I know that I have to take care of, and you have to take care of it all 24/7. But there just always seems to be something that's causing it. So what I see is a symptom, but there's something causing that. Excessive plaque buildup, gingivitis, whatever seems to come in that mouth, even though you've cleaned it out as much as you can, there's just something else causing this. So, I want to thank you so much. You gave me some really good information. I'm very excited to post this. I'm going to encourage everybody to listen to this whole spiel because I think it's, you did a really nice job of keeping it down to a minimum. It's a really big problem, but it's also, I think, a global problem, almost an epidemic in itself, Yeah.
And the question you had of how do we change this? I mean, we all have to just do what you're doing. I have my own platform, my to where I help to teach health professionals about all of this stuff, and then the other stuff like the sleepy strip stuff. There's a big mission with that's my invention, a big mission with that mouth tape to, once we start making some actual money back on our original investment, we really want to be singing and shouting from the hilltops about the importance of functional breathing, So yeah, that's and we just have to keep going with all these conversations, and we have to stop keeping with the idea that, well, don't we just breathe without thinking about it? So why do we need to pay attention? But the reality is homeostasis is controlling our breath, and the homeostatic systems in the body can become slightly dysfunctional and dysregulated because of the inputs on the nervous system, which is our environment, physical, mental, chemical, nutritional, all these different things affect the breath, and the breath then changes and tries to adapt, but it becomes dysfunctional. And that's what we need to talk about. A bit like people can become diabetic by eating too much sugar. Well, you can become a bad breather by spending too much time in a stressful environment. And that's right. So that's the kind of nutshell of it.
That's a very powerful statement. And I think this is the most appropriate time to talk about this. You know,
totally.
very, very important time to really highlight the integrated components associated, not the systematic, but the integrative components that are affecting our global health or our overall health. And, you know, I just think of our kids today and how, you know, we're not so much outside anymore and our eating habits have changed, and we're dealing with childhood obesity, diabetes in childhood, you know, oral, I see tons of swollen glands all the time in children from kindergarten up to like 8th grade who have speech problems, but that's not the problem. You know, when I says the airway, there's such a small airspace for them. And it's just amazing to see that maybe perhaps we just need to be looking another way and looking at breath first and foremost.
Yeah, it's number one priority for survival is that we can breathe. So
yes.
a whole bunch of symptoms come just to try and protect the breath. But so we see it somewhere else. We don't see the breathing because that gets looked after because it's the priority. Yes. But yeah.
That is very interesting. And I want to thank you again. This was a very, very wonderful conversation with you. It was very, very educational. And again, you just got to the point.
Yeah, you're welcome. Thank you. Yeah, thank you so much.
Thank you so much. Thank you.
Vlogs like this one are part of my Let's Mention Prevention video series on oral health. Thank you for sharing some of your time with me today. Ever onward.